Yes, I am Iacopo Baussano. I work at the International Agency for Research on Cancer. By training and practice, I'm a medical doctor, and then I moved to epidemiology. I come from the infectious disease epidemiology field, and then I moved to some hybrid field, which is basically cancers caused by infections. And in the last few years, I have worked a lot, essentially on trying to inform the decision process in public health. And we have used both field data and modeling technique. And what I've discovered over time, and I think it has been reaffirmed strongly in this year, is that with the COVID pandemic, there is a lot of trading off between what is observed, which are phenomena, and normally it's observed differently from different point of view. And then the ideas, which are the conceptual framework that are used to interpret what is observed. And then normally we have to compose all these visions in order to take decisions for public health and to make these happen. So I will try to develop this concept, this problem. So this is the outline. So I have a personal tribute to Rodolfo, who you can see. Basically, I try to represent Rodolfo on the right side. A very personal, then I will go on a very personal list of concept, basic concept. This lecture is going to be very subjective. So, I mean, you can disagree, but it's really going to be very subjective. It's a result of my experience. Then I will introduce the concept of infectious disease control framework, try to be extremely simple, and then I will apply it to an example, which is the HPV, cervical cancer control through HPV vaccination. So first of all, indeed, I attended, this is my certificate, the EEPE in 2003, which incidentally was the year of the first SARS epidemic, which was not as successful as the second SARS-CoV epidemic, and it's signed by Rodolfo. And it was a very critical year for me because I was moving really from medicine to epidemiology. And I think subjectively that Rodolfo convinced me that epidemiologists are healthcare professional. And that was very reassuring. And I have noticed that in a very recent interview he gave, the interviewer asked, what is your great disappointment? And I said, well, not having been able to pursue also some clinical activity. And that means that is very important for him. And that also means that I have the impression that Rodolfo is always trying to go for the next step. And that takes me to the second quality that I had the opportunity to experience while at IAR. We had a lot of discussion. According to me, the value of Rodolfo is that he's a problem framer. Probably he's also a very good problem solver. But what I really have learned from him is the capacity of not taking a problem as given, but try to frame it in a way that is creative, that is effective, and then try to solve it. And I think that this is reflected in two books, at least, that he has written. One is the epidemiology, the very short introduction, and the other one is the history of IAR. I have read several historical books written by scientists, and normally they are awful because scientists they apply a framework, conceptual framework, which is not adapted to history, but these books are not awful at all. And that means to me that Rodolfo primes, put the researcher attitude, which is skeptical attitude, on the top of a scientific attitude, which is essentially applying a technique, but never having doubt and never reorganizing the problems. So this is my tribute, and this is why I'm very glad that I have been asked to give this lecture. So the problem, I have been thinking a lot about how to start this lecture. And then in a blog, which has nothing to do with science, I have read this sentence from a person who is very well educated, which tells to another participant to the blog, well, what you have described is not reality at all. It is your perception. I was struck because I cannot really see whether that this sentence is correct or not, but it's thought-provoking. So, and this is something we observe a lot. It's a typical argument you have in public health. So the idea is that what you are saying is just your perception, but is not reality. Assuming that there is a reality, well, what we all assume is that there are hard facts, so unique external events which happens. But then from that point on, it's related to our perception. So how do we perceive these events and how do we interpret them? Well, perception is, of course, there are the senses, and then there are constructs that we have in our mind, education, and so on. So it's a very complex and very subjective, not necessarily arbitrary, but subjective. Of course, perception, and I will see you later, can be educated and in some cases quantified. And then we need ideas, theoretical constructs, to organize this perception and essentially to communicate them. And then is also a very important point in public health, because different stakeholders have different backgrounds, they have tasks, responsibilities which differs, and they have completely different perceptions and also way of interpreting what is happening. It's typical in vaccination campaign programs. You have to put together politicians, health economists, medical doctors, and people who want or sometimes do not want to be vaccinated, and in some cases are very militant in the fact that they don't want to be vaccinated and should normally advise other people of not getting vaccinated. At the beginning, you get irritated, frustrated, maybe sometimes aggressive, but then you have to compose all these components. So how do I go to the next slide? So as a phenomenon, as an example of a phenomenon educated, I have taken a medical case. Because of the training and let's say in honor of the interview given by Rodolfo. So medical doctors for centuries, I should say, have been educated in observing the reality according to a given structure. And if you go on the New England Journal of Medicine, every week you have a case record from the Massachusetts General Hospital, which is presented. And the structure is that there is basically a description of the phenomenon according to the tools that are available to doctors. So you have the age of the patient, whether it's a man or a woman, and the first symptoms. In this case, it's an 81-year-old man with fever, cough, shortness of breath, and so on. Then there is a clinical history, what this person has done. Then you have some tests, some clinical, let's say, laboratory tests. And in this case, it was a chest X-ray with a clear pneumonia, And then once you have observed these events, you have the hypothesis. So taken together, the above features indicate that the patient presents with a rapidly worsening pneumonia syndrome. And then you have the framework, the ideas, the conceptual framework. Well, we have which is called in medicine differential diagnosis. There are three hypotheses: non-infectious disease, non-infectious pneumonia, interstitial lung disease, and infectious pneumonia. Now, this case has occurred in the heat of the epidemic of COVID-19. So a priori, the possibility that we are dealing with an infectious pneumonia is very important. And therefore, the doctors applied the clinical models and they tested their hypothesis. And essentially, they did a nasopharyngeal swab and they found that the person was positive. And accordingly, they managed the case according, again, some theoretical structure, which has been organized and constructed through trials and audits and so on, and they insert the treatment. Unfortunately, in this case, the patient didn't survive. Now, how we can apply this kind of conceptual framework also to populations. So we move to patients, from patients to populations. We have public health facts, and then we have models and actions to be taken. There have been published, I think, thousands of COVID models in the last year and a half. I also contributed to the mess when I could. But I think this one is one of the best models that has been published. It has been published by a group in Harvard. Here you have the reference. And they do exactly the same. They adopt the same approach. They have actual data, which are the solid line. And then they have simulated data. And essentially in this paper, to let you know, they have used data from other coronaviruses, and they have tried to interpret the seasonality to project what could have been the seasonality of COVID-19 or SARS-CoV-2. And I think it works, their model still works very well. So essentially, in this case, we have epidemic curves. For us, this is the phenomenon. From our point of view, for the epidemiological point of view, Then we have the concept, or the ideas, which is the model, essentially, the transmission models and theory. And then we need some decision-making, control, about the control measures. Do we enact the lockdown? Do we use the mask? Do we introduce vaccination? And so on. Now, what I really like of infectious disease epidemiology is that essentially the entire control of infectious diseases can be summarized or synthesized in these apparently very simple equations. So everybody today knows what is the effective reproductive number, even children at school. But basically, this is the average number of secondary cases per infectious cases in a population over time, which is a bit different from R0 or R0. And the component of these effective reproductive number are 4. There is the probability of transmission of infection when contact occurs. Then there is the contact rate, which is determined by the underlying network of contact in a population. It's very much different for respiratory transmitted infections or sexually transmitted infections, as you can imagine. Then there is the duration of contagiousness. And then there is the fraction of susceptible individual in the population. There are 3, let's say, dimensions in which these component can be modulated. The biological factors of the host and of the parasite, the behavioral factors, normally of the host, and environmental factors. Essentially, in this grid, you can really summarize in this grid all possible ideas about transmission and control of the infection. So I think it's a very elegant and efficient system of thinking. For example, vaccination has the characteristics of artificially decreasing the number of susceptible, and if it is decreased up to a certain level, then we can take advantage of herd effect, which exists. It's much less stronger in sexually transmitted infections than in respiratory infection, simply because sexual networks are much more delicate and non-generic than respiratory networks. I will not spend time in the other cells, but I think you can use this conceptual framework also for, in another moment, and really try to fit your examples into this. Now, I am working on infectious agent-related cancers. The acronym is again IAR. And basically, these are the big killers in the world. Helicobacter pylori, which is the cause of gastric cancer. We have approximately a bit more than 800 cancer cases estimated worldwide. Then we have the HPV-related cancers, mostly the cervical cancer, but there is also some anal cancer and other cancers. It's about 700,000 in the world. And then we have liver cancers, which are related to viruses, hepatitis B and hepatitis C viruses, about 500,000. Most of these cases, overall, infection-related cancer are 2.2 million worldwide. Most of these cases are in low, middle-income country. And IARC works, of course, with the entire world, but now is really shifting the focus on low, middle-income country, trying to transfer knowledge and technology from high-income countries to low, middle-income countries. Okay, so now let's focus on cervical cancer. Cervical cancer, as you may know, is caused, the necessary cause of cervical cancer is the human papilloma virus, and therefore, worldwide, there has been a movement for vaccinating as many girls as possible. Now, this movement is not as successful or as rapid as we wish, but is progressing well. This picture comes from Rwanda, where we are monitoring the impact of the vaccination. Now, I have articulated this presentation, sub-presentation into 5 components. I will delineate what is the decision modeling approach, according to me. What are some fallacies about the modeling? And give you an example, and then to show you how data and context analysis and model have to interact. If you want, models are ideas and data and context analysis are the phenomena. I will show you a few cervical cancer models that we have developed at the agency, and then discuss briefly, if I have time, the problem of resource allocation and public health priorities. It's normally called the cost effectiveness, because cost effectiveness can be extremely misleading, and it can be extremely different, the use that we have to make in low middle income countries than in high income countries, then if I have time. Okay, so decision modeling. Decision modeling essentially is a methodology or is an activity which is used to draw prediction to support decision-making and planning. So the purpose that we have in public health decision modeling normally is to facilitate the adoption of specific control measures. And there is a lot of effort in developing technological innovations or managerial organizations, innovations which make this kind of intervention easy to adopt. But in fact, this is just half of the story. The other part of the story is that this innovation has to be adopted in a population. And to be adopted in a population, you have to convince the public health officials and the population that these things are useful. And then you need some kind of projections and predictions to discuss with these people. Modeling normally is considered only a set of quantitative techniques and algorithms, but this is again also only half of the story. We need also a good data intelligence, which is not just having high quality data, but it means also having a deep understanding of this data and how these data have been generated and they have been and how they relate to the context. The same data set in Rwanda or in Italy can mean two completely different things if it's not well interpreted. Now, it's really interesting to do modeling at the agency because IARC has a worldwide leadership in data intelligence, and it is an historical, I mean, it's really an historical heritage. In particular, if I just think about the monograph on one hand, and I think about the cancer registry on the other, this is fundamental. It really has shaped the vision of science from the agency, and is strategically positioned to inform public health decision-making, in particularly in low middle income countries, because not being a single government helps us a lot to interact essentially on a worldwide scale with many other actors without having prejudice against us. So to go back to the cervical cancer control, there are globally initiatives. One has been launched very recently by the World Health Organization, is the global strategy to eliminate cervical cancer as a public health priority. And the strategy is based on three extremely ambitious objectives, instruments, let's say, which have to be reached by 2030. So it means 90% coverage of HPV vaccination worldwide, 70% coverage of twice lifetime screening with HPV testing, again, worldwide, and then 90% of women having access to the treatment of precancerous lesions detected in screening or cancer treatment. Now, these are, let's say, aspirational targets, and they are fundamental to set a frame and to give the drive to this. But even assuming that this can be met in many low middle income countries, the adoption of this strategy means that probably the elimination could be reached by the end of this century, which is really demotivating when you have to talk to public health officials and convince them that, you know, when they will be long gone, then you will have an impact. So it is necessary when you act at a local level to adapt your kind of predictions and your kind of strategy in order not to be unrealistic, unachievable, and inequitable. Therefore, your data and your modeling, so your projections, have to be as context-specific as possible. There are a few fallacies in the global health modeling in general, and here I have found an example which is quite topical at the moment, and I really want to underline this just to learn from experience. This refers to the Global Health Security Index. The date is very important, October 2019. So the purpose of this, this index was to assess the state of international capability of preventing, detecting, and rapidly responding to epidemic and pandemic threats. And this was based on 6 dimensions. And of course, United States and United Kingdom ranked the best, and then the other countries. But unfortunately, 6 months later, many of these countries, and then 1 year later, all these countries were on their knees, and they were not so good in coping with all these things. I have the impression, that's of course very much subjective, that there are three important fallacies that we have to be careful about. First of all, data mystification. In many cases, when you are too high, you know, in your, let's say, too distant from the field, all data are considered to be created equal in terms of quality. And this is absolutely not true. Data extracted from Google are not as good as data extracted from the field and so on. Then the context is totally irrelevant. So you can exchange France, United States, Rwanda, exactly, and consider them, according to the 6 I mentioned, as if they were exactly the same. But this is not true, because they don't share the same system of value and the same public health priorities. So the political actions will be completely different. Think about some presidents or prime ministers, how they react at the beginning in front of the pandemic. This, simply make ineffective your kind of modeling. And then the idea is that models are omniscient. I mean, they know everything. Now, model can only answer the question they have been built for, if we are lucky. In some cases, the model can give you a result, but it doesn't discriminate. It is not able to support any kind of decisions. Of course, models are under big pressure from policymakers. So it's very rare that they say, look, I cannot answer the questions, but unless you give me more data and more information. But I think in some cases this should be done. So this is just to say that one size fits all projections are not convincing, and they're usually inaccurate at a local level. To be convincing and accurate, we need data. Essentially, we need data on risk factors, on the disease burden, and on available resources to have the disease control. And then we also need to know which are the needs of the country. Sometimes the country is well advanced already in the control of a disease. Sometimes it's not. Sometimes it's not relevant for the country at a certain moment to control a specific disease. If we are capable of considering all these elements, then we can have a local political commitment. We have the local healthcare community engaged in the process of control. And then we can also convince a civil society, a civil society partnership, which is fundamental. I am thinking here, for instance, about the anti-vax movement. It's very tough to counteract them without having the local political commitment and then having the local health care community engaged. So the modeling process has to incorporate this. And I will try to give you examples for what we are doing in some countries. So what about risk factors? Well, risk factors, this is, I'm thinking about HPV and cervical cancer. HPV is an infection transmitted by sexual behavior. So you need, and sexual behavior, as you can imagine, is not the same, neither over time, but not even geographically. It's strongly controlled by social norms. So here at the moment, we are modeling the introduction of vaccination in India. So the benefits and, the cost and all the barriers that we can have. So we needed data about the sexual behavior in India. We are lucky because the we had national behavioral surveys created by or made by the NACO Center for All India, which is big in behavior. All this information can be then used to create or to simulate a sexual network. And then from India, we have the possibility to have a study on the right-hand side, in which basically we measure the prevalence of HPV types, carcinogenic types and non-carcinogenic types in India. IARC has a long history of doing these HPV prevalence surveys. They were started by Nubia Munoz in 1995-6, and then they were taken over by Silvia Franceschi and so on. And we are going on with these surveys, even if the methodology is a bit different. And we try to map the world. And as you can see, there is a huge difference. It's almost one order of magnitude of prevalence, difference of prevalence in exposure. And this is entirely due, or almost entirely due, to difference in sexual behavior. HIV plays a small role. It plays a role, but it's very small. So that's about the exposure, the risk factor, the exposure to risk factors. Then we need information, as I said, about the burden of disease. And for cancer, of course, the gold standard are the population-based cancer registries. In case we don't have this population-based cancer registry, Then we have a database at IAR, which is essentially constructed through projections, which is named GloboCan, is updated every 2 years, and then can be used to make either geographical comparison, GloboCan in particular, or making a chronological comparison, so to estimate trends of the cancer in some countries, only in some settings. These are very precious information. I have tried to put references and links, so I think you can use them if you want to go deeper in some aspects. And then, so I want just to stress one point, that the population-based cancer registries are available in less than about 1/3 of the countries worldwide, and most of these countries are concentrated in high-income settings. They're not extremely expensive, to be honest, but they need solid organization, a long follow-up, and a quality control. So it's a long-term engagement for countries, and many countries at the moment are not very much keen in introducing them. Essentially, I think because of the cancer, you know, it's something given, and the latency between the exposure and the cancer occurrence is so long that people don't think it's worth investing on that. But that's, again, is my personal opinion. So, and then we need information about available resources. In this case, I'm considering vaccination, screening, and treatment, which are the 3 main pillars of the elimination strategy launched by the WHO. Now, we need information about how feasible is a measure, how affordable and how sustainable this is. Now, vaccination, it's fairly easy to get information, essentially for the expanded program of immunization that we have in every single country, which depend from the Ministry of Health. They report to WHO, they can give us information about coverage. And we also can extract information about recurring and non-recurring costs. Nevertheless, if we go in the country and we do studies, then we can discover things which are very important. I think the graph on the right side, on top of the right side, is very interesting. It's a study we have conducted in Rwanda. And essentially, we managed to couple the data about the age or the birth cohort of the girl and the coverage of the vaccination. If you read the report, the official report, they state essentially that the coverage was extremely successful and we have 90% coverage across the countries in all ages. Well, this is true, or almost true, for populations, for girls who were vaccinated when they were 12-year-old. And this is because they were vaccinated within the school system. The entire vaccination program against HPV in Rwanda and in many countries is embedded within the school systems. Now, the fact is that girls, when they are, and we had catch-up strategies, which went up to age 15 or 16. Now, these girls here, many of them drop out of the school, so they are not reached by the vaccination system. And therefore, in these girls here, in this age range here, we have much lower vaccination coverage than 90%. And this can be relevant for them in terms of prevention of cancers. And if one day Rwanda wants to try to implement the screening, maybe they have to target screening differently to this birth cohort than this birth cohort. Or we can do a second catch-up strategy campaign of vaccination. So for vaccination, in any case, we can have many information to inform our decision. For screening program, the story is completely different. IARC has started an initiative, cancer screening in 5 continents, a repository of information for cancer screening program. You can visit it. Basically, it's fairly empty because the international availability information is poorly harmonized. And there has not been ever an attempt to do that. We are starting this. It's very interesting, but I think it will take at least 5 years to be able, if we are optimistic, to be able to obtain usable data. For treatment and care, it's even worse. Essentially, every single country has its own information. They're not harmonized. In many countries, it's extremely difficult to get information about how many people access and how much it costs, because the healthcare is basically private, and essentially hospitals don't disclose the rates and how much it costs to be treated. So this is a black spot at the moment, and we don't know how to solve it. Except doing studies in the country, but in many countries they don't just, either they don't have the data or the data are not accessible. And then we have to assess the local needs. So here is a timeline of the Gavi countries which introduced vaccination. The first two countries were Bhutan and Rwanda, and this is why we worked in these two countries, and then many other countries followed. As for today, okay, the timeline is, for instance, Cambodia, in fact, has not yet introduced, Mozambique has not yet introduced or is introducing, so there is some delays. But you can imagine that the needs or the situation of a country like Cambodia and Mozambique is completely different than a situation like Bhutan and Rwanda. And of course, they have we have to support completely different decisions. Some countries we have to just understand if they want or not to introduce vaccination and when to do it. In other countries, we have to start to help them to decide which age groups and which gender should be targeted by the vaccination. In other settings, we have to support, for instance, the decision about which vaccine type, dose schedule, delivery system, and if there are any specific groups which are not covered by the delivery system, and how to target them. I'm thinking about nomadic populations, for example, or a large fraction of immigrants. And then for the most advanced programs, which are already implemented and fully working, it's essential to monitor the impact and to adapt the impact and the resources according to what is actually happening in the field with vaccination. So to do that, we need adaptable models. Essentially, we need to trade off the model flexibility and the demand of data to inform this model. Access to data is highly unequal to across settings and countries. So what we have thought about at IARC, and now we are implementing, and this was a reflection that started with Silvia Franceschi and Martin Plummer, was to develop not only one model, but a suite of models, which are really designed to answer questions of different complexity and to incorporate, if available, data of different complexity. Overall, we try to give targeted, informed, and transparent projections. Targeted, as I say, they have to answer the question. Informed means that they have the right level of data that we need. And transparent, I think for many of you may be surprised, but basically the largest fraction of the transmission model or predictions model that you can read in papers are not falsifiable, because they are proprietary and they are never shared by the, almost never shared by the authors. So essentially it's an act of faith, you have to trust them. So we are trying to use open source and replicable and adaptable model that can be at a certain moment either shared with partners, or they can be downloaded one day. We are even planning, if we have resources, to start to do some training for groups or research groups or public health groups who want to enter this field. Now I will give you an overview about the model. We have developed three, in fact there are more, but let's say three frames of model. One is Atlas, which is the basic one. One we call it Pandora, which is the intermediate. And the third one is METHIS platform. So the first one is the simplest and is informed essentially with publicly available database, which are available essentially to anyone. And I will not go in details for each information that we introduce, but here in pink, or I don't know what is the color is, but in this with the colored boxes, you can see what we had and the complexity that we have to add for when we increase the complexity on the model. Essentially, we need information about demography, about infection and cancer occurrence, and about the prevention. And the output we have from this model is the risk of infection or cancers, and then which has been articulated either lifetime or by age of the women, by period, or by cohort. Okay, here is Atlas, or at least, I depict Atlas. It's very simple. It's based on age-specific incidence, and source is GloboCan. So we can give prediction for 195 countries. And then the demography is obtained through the United Nations demographic projections. They are both inputted in Atlas. And we postulate an impact of HPV vaccination. Let's say we postulate that we can decrease the prevalence of HPV by vaccination by 80%. And therefore, we can estimate the lifetime risk of cervical cancer. It's not flexible, it's country specific, but it already gives many information, or I mean, sufficient information from, to countries. Here you can see the 9 countries in which 50% of worldwide cancer burden will be concentrated for the birth cohorts who were born between 2005 and 2014. Now, in the large majority of these countries, vaccination has not yet been introduced. And so you can, for instance, for India, you expect in this 10 birth cohort, 1,800,000 cases. And if you introduce vaccination with cross protection, so not the best existing vaccine, which is a non-avalent, but is more expensive, you can already reduce a bit less than, a bit more than 1.5 million cancer cases in this birth cohort. And these are birth cohorts walking in the street. These are young women. So they are all in principle vaccinable today. So this is enough to take a decision whether a vaccination is worth introducing or not. And you can also attach, honestly, some costs and some predictions about the, let's say, financial or organizational burden in a country. Then we have developed PANDORA. PANDORA is interesting because here, instead of having, let's say, the data from Globocan, we have age-specific HPV prevalence data, which are obtained from surveys in the field. And we are capable, using this model, to predict the cervical cancer incidence in specific birth cohort. Essentially, you give the HPV prevalence, you pass the average age at sexual debut of a certain birth cohort, and you can extract, you can predict the expected cancers. In places for populations, I mean, for settings in which the country is not representative, when we talk about India, we're talking about a huge extension of settings and populations. So we can have a prevalence survey in a specific setting, and for that specific setting, we can make predictions. And of course, then we can introduce the impact of vaccination, and we can estimate how many cancers or what incidence of cancers will be predicted in will occur with and without vaccination. And this is what we are doing now with Bhutan. This is a study. In Bhutan, we did 2 prevalence surveys. You have to think that we went essentially to measure the prevalence before the introduction of vaccination and the prevalence after the introduction of vaccination a few years later, 2011-12, the first survey, 2018, the second survey. And then we have this information stratified by age. And here you can see that essentially the prevalence, this is the prevalence of HPV types targeted by vaccine, 6, 11, 18, and 16. And this is the prevalence that you observed after the vaccination, in the same age range, but not in the same birth cohort. What is interesting is that in the types not covered by the vaccine, we observed an increase of the prevalence. Most likely, we have the data attributable to changes in sexual behavior. This survey was conducted in the capital, where the social control is less strict than in rural areas. So in fact, without vaccination, this curve also would have gone up. We can pass this data to PANDORA, and then we can estimate the expected cancer. It's a counterfactual exercise. This is the expected cancers, number of cancers that we would have had in this birth cohort in absence of vaccination and with impact of vaccination. These are fairly simple models to use and fairly convincing for public health officials. They have already introduced, so they don't need our projections, but it's very good to them to show that they have an impact, and they will, and they most likely will have an impact on cancers. And then we go for a more complex.
Iacopo, if
yes.
you want to know, you have like 5 minutes left.
Okay, I'm almost done. Thanks. And then here is the METHIS platform. It's extremely complex compared to the others. Essentially, we have 2 models, one for the transmission and the other one for the progression. METHIS, the first one, PROMETHEOS in the other. Here, you really need a lot of data, in particular about sexual behavior. But the advantage of this, if you have this data, is essentially you can simulate different types of intervention and compare them head to head. So you really can fine-tune your control approaches or strategies. And I will show you some examples, a couple of examples that we have from India. So now, as I said, we are working in the HPV vaccination in India. So METHIS, essentially passing the input data, I will not spend time on that, and simulating the introduction of vaccination with 60, 70, up to 100% coverage. We can see what is expected and what is going to be attributable to the direct effect of vaccination and the herd effect, so the indirect protection. And we can have this information, as I said, for both boys and girls, at a certain age or a certain period, and so on. So it's extremely flexible, but it took, well, to build the software took a lot of time, but to calibrate the model took about 1 year. So, I mean, and to start to have this project. So it's a lot of work. Then we can pass this information to PROMETHEOS. We can reproduce, as you can see on the right-hand side, the cancer incidence in one state of India. Here we work state-wise. This is the solid black line, whereas the orange line is the model predictions, and the type of cancer which attributable, I mean, cancer attributed mostly to HPV 16 and 18 in absence of vaccination, and then to other types. If we introduce vaccination, then here below, you can see that our orange curves goes down, and most of the cases are attributable to other types. And this is without screening. So if we add screening, then we can tailor the screening to the expected incidence and also to the expected types in the population. Now, I want to spend really 1 minute on the costing. Costing is very fashionable, it's very attractive. People think they understand it, but in fact, it can be extremely complex. On the right and on the left-hand side, you can see what happened to the prices of the vaccine, bivalent, quadrivalent, and nonavalent, not enough data, over time in Europe. Essentially, due to market forces, the prices went down. There was competition. What is interesting is that the black dots, which are the prices assumed in the cost effectiveness analysis, have nothing to do with the reality, what really happened. Okay, so in the cost effectiveness analysis, the major driver, one of the major driver of the decision of whether something is cost effective or not is the cost of the vaccine. So I leave you to imagine what was the influence of these studies with wrong prices in their as an input. This is the same study, which is very interesting, done by a Dutch group with which we collaborate, also was capable of identifying the main forces. So the valency, of course, increases the vaccine, the prices of the vaccine, and competition here and here decreases the prices of the vaccine. In low middle income countries, the most important, I mean, in high income countries, we have the money to vaccinate people. We can, we can discuss if we don't want to vaccinate, but at the end of the day, as we have seen with COVID, I mean, if we really need, we have to. In low middle income countries, the first thing to think about are affordability, opportunity cost, and sustainability. So the framework of cost-effective analysis should be adapted accordingly. So in summary, I have tried to describe that public health decision modeling is based on methods and data have to be really contextualized and understood according to the context. We need to set credible targets to be sustainable and acceptable from the government, the public health officials, and the populations. And we don't have to jump to the most complex model if we don't need it. We need a range of models of increasing complexity and use and pick up the one we can afford in terms of data and the one we need in terms of questions. And then when we combine, at least from a WHO perspective, I mean, from a health perspective, when we combine impact with resources from a public health point of view, benefits should always drive the decision process. And lack of resources, of course, is a limitation, but I mean, it should be addressed as a limitation, not as a decision factor. If we try to be simply wise men instead of doing super duper prediction and thinking that we are like gods, maybe this would help as well. So I thank you for your attention. I want to acknowledge all the people that collaborated. And just to tell you, our work is mostly funded by the Gates Foundation and by the European research funding programs. Thank you very much for your attention.